Imagine this. A 65-year-old patient, he is on ventilator for a week, deeply sedated with midazolam in last 7 days, and today he is off sedation but very agitated, thrashing, pulling at his tube. The team is anxious and the family is distressed to look at him. This is not just agitation. This is delirium. The brain is in crisis. My name is Dr. Saf, your trusted educator in ICU, and today we are going to discuss ICU Delirium, an important critical care exam topic for all the critical care trainee who are actively enrolled in DM, DRNB, PDF, and Saudi Board ICU exams. So, delirium is basically acute brain dysfunction characterized by fluctuating course, inattention, and altered consciousness. It is highly prevalent, affecting 30 to 80% of ventilated ICU patients. It's quite common. It is a major concern for all of us because it is associated with increased mortality, prolonged mechanical ventilation, and long term cognitive decline. Agitation is highlighted as the most visible and dangerous manifestation, posing risks of self-extubation, risk of removal of essential lines, for example, central line and staff injury after all. So it is important to control the agitation. So we can prevent bad outcomes by early recognition using validated screening tools. So there are multiple tools available. So tools which are available are so many, but usually we use two most common tools to assess the delirium. The first one is CAM ICU, which is confusion assessment method. It is a rapid bedside assessment, and this is quite suitable for mechanically ventilated patients in ICU. So what does it assess? It assesses the acute change or fluctuation in mental status. That is feature number one. Feature number two is inattention or lack of attention. Feature number three, altered level of consciousness, which is assessed using Richmond Agitation Sedation Scale or RASCO. And fourth, the last feature is the disorganized thinking. So CAM ICU is considered positive if feature 1 and 2 and 3 or 4 are present. So three features have to be present to say whether CAM ICU is positive. So regarding its performance, it has a good performance to detect ICU delirium with high specificity up to 95% and a very good sensitivity of 80%. So you should remember the diagnostic performance of this test. The second standard tool is ICD-SC, that is Intensive Care Delirium Screening Checklist, which has 8 items designed to be completed over an 8 to 24-hour period to allow for continuous monitoring. 1 point is given for each symptom present, and maximum you can have 8 score, and a score of more than 4 is usually considered positive for delirium. Again, it has a very good performance, a comparable performance with sensitivity of 74% and specificity of 82%. Now we will talk about the key clinical features of delirium. So delirium manifests through a variety of symptoms which often fluctuate in severity throughout the day. There is often inability to focus, maintain or shift attention, and thinking becomes disorganized, and there could be rambling or irrelevant conversation. When you try to talk to the patient, you will know that they don't have any relevance in talking, and usually the flow of ideas will be unclear and quite unpredictable, switching between topics. And the level of consciousness also fluctuate a lot from hyperarousal to hypoarousal state, is quite different from coma or deep sedation. Delirium is usually classified by psychomotor behavior, with the hypoactive form or hypoactive delirium under recognized, but it is the worst form. So suppose someone has hypoactive delirium who seem to be quiet and withdrawn, and with some apathy, some responsiveness which is very slow. So it is difficult to recognize and it is often missed, and unfortunately it is more common type. About 80% of ICU patients have hypoactive delirium, and it has also worse outcome. Patients may exhibit fluctuations between both hypoactive and hyperactive deliriums, and as you know, usually what we see and what is visible, I should say, in ICU is the hyperactive delirium, which is marked by agitation, restlessness, and often emotional outburst or hallucinations. These are the two main types of delirium. Now, what are the factors which should be looked for and to be presented? These factors are very important to remember, okay, like advanced age, more than 75, pre-existing dementia or cognitive impairment, chronic use of alcohol, and functional or sensory impairment. All are usually precipitated by hypoxia, metabolic derangement, and hyponatremia, etc. Even sleep deprivation can cause this. These are main precipitating factors. Then we should know some iatrogenic factors or management related factors which could be modified using various interventions. Okay, so in ICU, deep sedation frequently linked with benzodiazepines, like if you are using lorazepam or midazolam, the incidence of delirium is going to be up. And use of physical restraints associated with high risk of agitation. So implementing the ABCDEF bundle is highly effective in reducing these type of risk factors. Management of ICU delirium is very important to know, and remember that it involves both non-pharmacological and pharmacological measures, and you should try non-pharmacological measures first. Okay, this is very important. So to improve sleep hygiene, so sleep hygiene is the most important non-pharmacological management, and it involves the quiet hours. So you should introduce some hours of sleep and cluster the care ICU care activities to reduce the entries of staff and patients relative, and limit the noise below 40 decibel. Offer earplugs, eye mask, and back massages also help a lot to improve the total sleep time, and thereby reduce ICU delirium. Although results in studies vary, avoid unnecessary nursing procedures during night to protect sleep architecture. So you have to take care of day night scheduling, a day night pattern of sleep in ICU patients. Okay, so let them sleep more in night. Initiate early progressive and active mobilization, for example sitting on the edge of bed, walking, cycling, within the first 2 to 5 days of ICU admission. Early mobilization is safe and feasible for patients on on low dose suppressors, like suppose patient is on norepinephrine less than say 0.2. They can be they can be mobilized. Even the patients on ventilator could be mobilized, obviously with the staff who is aware of how to mobilize and trained for that. Reorientation, I always say this is important. Reorientation in the form of putting a clock in front of patient, a calendar. Now implementing the flexible or even unrestricted visitation policies, encouraging families to engage in simple care tasks like assisting with meals, brushing hair, utilize family members to provide comfort, speak to the patient and reduce anxiety, which can decrease the incidence of delirium. So basically involve family and caregiver more and more. Maximize natural day light and keep the patient in comfortable position. That also helps a lot. When a patient experiences severe hyperactive delirium, a state of severe confusion, agitation, and hyperactivity, and non-drug approaches or non-pharmacological approaches aren't enough, or the patient's safety is at risk, medication becomes necessary. So there are some indications to use the drugs in delirium. The main aim of this intervention is to manage the distressing symptoms and ensure patient safety and staff safety. So it is crucial to avoid using benzodiazepines excessively, as they can lead to oversedation, which is undesirable. Basically, oversedation just converts one type of delirium to other type of delirium. However, they are preferred agent for agitation specifically related to alcohol withdrawal. Dexmedetomidine or Presidex is a sedative medication often used in ICU. It is known as cooperative or conscious sedation. It has anxiolytic effects and allows patient to remain somewhat alert compared to other sedatives. So it can shorten the length of delirium, improve sleep pattern, and decrease the need for ventilator. It is most suitable for ICU patients who need sedation but not to the point of being in deep coma, especially when managing agitation while still waiting the patient to be able to interact. So Presidex is being used nowadays a lot. Almost all patients of delirium are kept on Presidex. Haloperidol is common medication used to quickly calm patients experiencing acute agitation. It is effective for sedation, but it doesn't necessarily shorten the overall duration of delirium. Instead, it tends to change the type of delirium from hyperactive to hypoactive delirium. So it does not actually treat much. When using haloperidol, it is important to watch out for QTC prolongation and also for extrapyramidal side effects, which are movement related problems. So don't use haloperidol much. Now we have atypical antipsychotics like quetiapine and olanzapine, which can be used as alternative to haloperidol for long-term agitation, particularly when less sedation is needed. Quetiapine might help reduce the duration and severity of delirium in ICU patients, especially hyperactive delirium. For a patient with hyperactive delirium, the starting dose of quetiapine should be 50 mg twice daily, which can be escalated to maximum of 400 milligram BD. So don't start quetiapine with lower doses. Start with 50 milligram BD. It is quite safe. Just to monitor LFT and QTC interval. Okay, these two things should be monitored. And dose adjustment is needed in case of hepatic dysfunction. If LFT is deranged, definitely you should be able to adjust use the lower doses. Okay, now olanzapine is also used as a off-label medication for its quick sedating effect, and it is as effective as haloperidol. However, high anticholinergic effects can lead to oversedation and potentially prolonged delirium in older adults. So again, olanzapine is not a very good choice, but is okay to be used in patients who are not being controlled, or you say they are still having the hyperactive delirium despite Presidex or despite using the quetiapine. You can probably consider olanzapine. The other drug like risperidone is also available. Some people use lorazepam. That is not actually again preferred. As I said, it increases the incidence and duration of delirium. It worsens the delirium basically. So don't use lorazepam or clonazepam to manage the delirium. But you can use the ICU Liberation Bundle or ABCDF bundle, which maximizes outcome, the good outcome, and minimizes delirium. So this is a structured interdisciplinary approach to manage pain, sedation, and mobility, and it can reduce the delirium and coma days by 25% to 50%. So I have created a separate video which you may find in the library on my YouTube channel. Thank you so much for attending.